Hello and welcome to the Nurse Rosa's Insights podcast. I'm your host, Rosa Hart, and today I'm joined by Phyllis Farrell. Thanks you so much for joining me today.
Hi, Rosa. I'm so thrilled to be able to be here with you.
I am so honored to have you. We met a few months ago when you were giving a talk at our Alzheimer's luncheon, and I was just so moved by your story and I guess your motivation picked up with me. I talk to a lot of people who struggle with brain health related to stroke, and your field seems to be a lot more focused on Alzheimer's and dementia, but there's a lot of overlap and there's a lot of similar things we can do to prevent dementia as well as stroke. And so I really appreciate this opportunity to talk to you some more about that today.
Great. I'm happy to do it. And you're right. There's a lot of overlap between vascular complications like stroke and brain health. So I think it's a wonderful thing for us to be able to talk about that together.
Yeah. Now, Phyllis, your career spanned pharmaceutical leadership at Eli Lilly, global advocacy, and now venture innovation in brain health as well. So, before we get into the $1 billion question, I'd love to get to know more about you and your varied perspective, and kind of what led you to the point of influence that you have now. So, looking back, what do you feel like most shaped your passion for brain health?
Well, so you're right. I worked for Lilly for almost 30 years. Um, Lilly's headquartered in Indianapolis, and I'm calling in from my kitchen in Indiana, in a small town just north of Indianapolis. And my first half of my career at Lilly was a very traditional commercial career. So I have an undergraduate degree in economics and a master's in business. And I did marketing and sales and global and US in women's health and neuroscience. But about 15 years ago, the company asked me to come over and lead the Alzheimer's disease team, where we had responsibility for the late stage development, so all the regulatory processes and clinical trials, through to launch for the therapeutics and the diagnostics. And that was a big change for me. I spent the second half of my career doing that. But what really fueled my situation is about 6 months after I took that job, my dad was diagnosed with Alzheimer's disease. And we hadn't had this experience in our family. My grandparents all passed away very young. And so we didn't really see this coming. Um, I don't think he actually had Alzheimer's disease, so we can talk about that.
Oh,
But I lived this personal and professional journey for the
mhm.
next 7 years, and now even on past, his death, because I realized that I had every access to every, thought leader in the world and all the science, and it was such a difficult experience for our family that I just knew we had to do better. And so I actually went back at age 50 and got a doctorate degree in public health, because I decided that brain health needs to be on the public health agenda, and it's not today. And, I think about my daddy all the time. It's why I do what I do. And I just don't want anyone else's sons to grow up without their grandfather. It's like mine had to. And there's so much that we can do now because of the advancements in the science.
Yeah. And I hear you there. My son, as much as I want to take them on trips to see historical things on fall break or spring break, my son tells me his favorite place in the world is at his grandparents' house. And so
Wonderful.
anytime that we're planning a trip, he's like, or we could just go to grandparents' house and that could be enough.
I know.
So, I mean, you're right. It is so important to them to have those relationships. So I'm really sorry that happened with your dad.
Well, and I had boys that were athletes, and my dad was big into sports. And the number of times that I thought, gosh, he should be here. He should be here to watch this basketball game or this baseball game or come to these awards. He would have loved. He would have loved every minute of it. And he just never got to do those things. And so anything we can do to slow down this disease, prevent it from happening, slow down the progression, give people more years with their loved ones, we should be doing.
Yeah. And obviously, there are genetic factors, there are environmental factors, but Why did you think he didn't have Alzheimer's?
So, one of the problems with Alzheimer's disease, well, let's call it Alzheimer's disease and related dementias in this country,
Mhm.
is that very few people actually get a diagnosis.
Mm,
Those that do get diagnosed very late, and they don't get an accurate diagnosis. So, what happened with my dad was he probably had 6 diagnoses in the span of about 7 years. One of those was Alzheimer's disease. But he had a lot of other kind of things thrown at him. And, the brain is kind of the next frontier. So, when you have someone that either has an unusual presentation or, quite honestly, even our earliest clinical trials before we actually had amyloid tests, we were wrong. People didn't have Alzheimer's disease 25-30% of the time in a clinical trial for an anti-amyloid agent. And when my dad got sick, we didn't have the diagnostics that we have today.
mm,
Now we have the ability to say, is this amyloid pathology or not? And if it's not, let's go figure out what this is. It could be a reversible cause. Geriatric depression looks a lot like Alzheimer's disease. Now, my father didn't have one of those things. He had some sort of neurodegenerative disease. We're
mm.
still not sure what it was. But boy, the process of trying to get a diagnosis was so difficult for our family. And if we had had some of the technologies we have today, like blood tests and PET scans, it would have really changed the experience for my family.
Yeah, definitely. And then how have you been able to use your professional career to make things better for other families?
Well, so at towards the end of my time at Lilly, they did something very wonderful for me. They actually put me out on secondment as an executive on loan to the World Economic Forum. And some people may or may not have heard of the World Economic Forum or this big meeting that happens in Davos, Switzerland in January in the snow. But one of the things that's unique about the World Economic Forum is it's the one place where the public sector, governments, and the private sector, business, are allowed to kind of work together and funds can intermingle. And we had been really, really successful as a field getting all of the multilaterals, think like the United Nations and the World Health Organization and the G7 and the G20 and the OECD. We'd gotten them on board that dementia and Alzheimer's disease needed to be a priority because we had these global aging populations, and
Mhm.
age is the number one risk factor for Alzheimer's disease. But the problem was these things were all sitting on paper. They were communiques, they were declarations, and quite honestly, they weren't coming down off paper and getting into a patient's experience. Like they
Mhm.
never got to the bedside. So while I was doing my public health degree, I came across Gavi and CEPI, which are these two very large um, public health initiatives that actually started at the World Economic Forum. And once again, it was that place where the government, the public sector, and the private sector were allowed to work together. So Lilly put me on secondment and we lobbied the World Economic Forum. And basically, I started kind of working as an executive on loan with the World Economic Forum to create a new organization, which is the third global health initiative behind Gavi and CEPI, and it's called the Davos Alzheimer's Collaborative, or we call it DAC. It has several missions, but the one that I lead is what we call health system preparedness. And its whole goal is to take these clinically ready innovations, so things that have been gone through research, they've gone through the regulatory process, they're ready to be used, and make sure that they get to patients and they get to a different experience. Unfortunately, science shows us that it takes about 17 to 20 years for a new innovation to become standard of care. And I just don't think we should wait that long. So we now have a full initiative that is focused specifically on that. And so I decided to take early retirement from Lilly. And that's what I do now is I work with that organization and related organizations to try to move the field forward so that all of this fantastic research and hope that's coming out of academia and industry actually changes a patient and a family's experience with the disease.
So, in your experience, is it more often regulatory barriers or the cost of implementation that makes things take 17 to 20 years to get implemented from the time you're discovering, oh, we have a solution to we can roll this out and this is standard of care.
That 17 to 20 years is post-regulatory approval. So it
Okay.
really has nothing to do with regulatory. I mean, there are a few things like promotional language and things like that that can get caught up in it. It really has to do with access.
Hmm.
So in the case of the US and a 65 and over population, will Medicare pay for this? Will Medicare Advantage pay for this? Will commercial payers that run those Medicare plans pay for this? So there's an access component, but it really actually has more to do with making change in the healthcare system. Um, it's really, really difficult to do health system transformation. And I'm here to tell you it's not for the faint of heart. Um, it's especially difficult in the United States because we have these vertically integrated systems, right? Every hospital and institution can kind of do what they want,
Hmm.
provided that it's within the regulatory guidelines. So,
Hmm.
different workflows, lots of complexity and billing codes, and quite honestly, just introducing people to each other who haven't really worked together before. And that takes time. But for me, those are engineering problems, right? Those are solvable problems. Give me people to introduce to each other. Let me
Right.
go tell a patient story and get them motivated to do this. And it's really kind of chipping away at those barriers.
So in that way, you're like a human engineer, and that you're engineering human connections to to bring.
Match.com for health systems. But
Oh man.
it's interesting. We've done now some of these programs, and actually Norton Healthcare in Kentucky is the reason that we met. It's one of the beneficiaries of a DAC grant, and we have found that the number one criteria. You want to guess what it is? Number one success criteria?
You'll have to tell me.
It is a tenacious, gritty, persistent champion.
Yes, I love
That is
that. There's
that
hope.
is the num and I will tell you, we've now done 70 programs on 5 continents in 19 countries, and in every
Wow.
single country, high resource countries, low and middle income countries, United States, Europe, Japan, it's always the same. And that kind of makes sense, right? Find a place where you're trying to make change. It always takes a change maker
Mm.
and someone willing to do that. And that's been really fun because those are the people I want to work with anyway.
Yeah, I have been honored to meet so many in so many different areas, but so many of the times we feel like we're screaming into a void. Like in my stroke world, sometimes we will have innovations that we see could be making a difference, but there's so many barriers to, like, well, this is how it's always been done,
Oh
or
yeah.
just overcoming these pre-existing understandings based on before the science was there, right? Like the advancements in stroke thrombolytics. There was so much fear. There still is some persistent fear of, about using thrombolytics or having a mechanical thrombectomy in an acute stroke, even though it's been proven, but there's that human factor of experience that has to, um, come about. So, that is so encouraging to hear from you that, it's worth being the drippy faucet, essentially.
I always say I'm yelling in a crowded room is what I say.
Mhm.
And then you find your person, they're over at the punch bowl and they're waving, going, I'll help you. And I'm going to get there. And so it is a product of the US health system. There is a lot of autonomy. So outside the United States, typically changes can't be made until a policy is changed because you have these large single payer systems.
Mhm.
And so, we often say, in Europe, you have to go pilot policy practice. In the US, we can go pilot practice policy, which is wonderful because you can find those change agents. You can find those first movers, people who want to make change, people who are willing to try something new. They're willing to pilot. They know it's going to be a little bumpy in the beginning, but they're interested in trying to make the change, and they can do it without necessarily waiting for a policy change. You still have to have regulatory approval, and it's really
Mhm.
helpful if Medicare pays for something. But, they don't necessarily have to wait for some, an NHS board to make a decision. And that makes for I think a healthcare system that allows us to try new things. It also, though, provides a healthcare system with a lot of variability because it may depend on where
Yeah.
you live as to whether you get that experience. So if I live in Louisville and I go to Norton Healthcare, I may have a different experience than I live someplace different because there I have
Mhm.
a system that's willing to try some of these new innovations, whether those be diagnostics or therapeutics or just even care flow.
Exactly. So, when you are addressing barriers to like trial participation in
Mhm.
Alzheimer's research, um, I feel like there can be a lot of like hesitation in the community of not wanting to be a guinea pig. How would you go about addressing that?
It's interesting. I've done a lot of trial work, obviously at Lilly, and patients that think they have Alzheimer's or at risk of Alzheimer's or may have Alzheimer's, they're different. They don't want placebo. If they come into the clinical trial, they want active drug. And
Mm,
so this idea of kind of the guinea pig, which you may see in other disease states that have treatments, right? So part of that is I'd rather have something that's tested and proven, let somebody else be the research participant. Well, in Alzheimer's disease, we really haven't had anything. In fact, until these two new drugs were approved, we hadn't had a new approval of a therapy in 35 years. 35
wow.
years. And so clinical trial participation barriers for people that have Alzheimer's disease and related dementias are a little bit different. We don't so much have that kind of reticence. The bigger issue is actually the same problem with care, and that is we know now that because this is a progressive neuropathological disease, right? So, when you lose your neurons, when your synapses have dysfunction, when you're losing, in the case of Alzheimer's disease, your memories, they don't come back.
Yeah.
Um, when you lose them, they're gone. And that doesn't mean there isn't brain plasticity and there isn't way to regrow, but you can't get those back. And
Hmm.
so what happens is with the new therapies is we know that catching this disease earlier is better. Now, that shouldn't be a surprise to anybody. Um, who wants a stage 4 cancer diagnosis when they could have had a stage 1 cancer diagnosis? Nobody does, right? There's not a single disease where it's better if you catch it late. But in the case of Alzheimer's disease, we really have been catching it late. So the bigger problem I have is I'll have people call me and say, Phyllis, my mom's been diagnosed with Alzheimer's disease and they're telling me she's too late for a clinical trial. And to me, that's the travesty, because someone doesn't go to bed cognitively normal and then wake up with dementia the next day, right? This is a slow
Hmm.
progressive decline, and by not catching it early, you've taken the option away from that person to participate in a clinical trial if they wanted to. And
Hmm.
even more importantly, we have about 120 new therapies in the pipeline right now across 140 studies. We will need about 50,000 patients to enroll those studies. And right now, we're only enrolling about 13,000 patients a year. So we have an incredible opportunity if people do want to participate in trials to move the whole field forward faster.
Yeah.
And, those trials are for everyone cognitively normal, mild cognitive impairment, early dementia, biomarker studies, observational studies, therapeutic studies. There's so many of them. So I'd like to see more people getting diagnosed earlier or at least having the conversation with their doctors about brain health. And then their doctors saying, you ever considered participating in a trial? Because you may be able to move the field forward. And for a lot of us who've had this disease in our families, we would love to play a role in moving the science forward more quickly.
And could you speak to the importance of women being willing to participate in these trials?
Absolutely. So, Alzheimer's disease is really a disease that impacts women disproportionately than men, both as patients. And for a long time, people thought that was just because women live longer. Once again, age the greatest risk factor. So they thought, well, that's why women get Alzheimer's disease more than men.
Mhm.
But now they've found even when you control for age, women still get the disease more frequently. They
Mm.
also have a different presentation of the disease. Once again, this isn't a surprise. Women are not little men. And, we know this from, remember all the work that the American Heart Association did on heart attacks, how the symptoms in women look different and than they do in men. Well, it's exactly the same thing. The progression and symptoms look different in women than they do in men. And we haven't spent enough time exploring that. But in addition to that, Rosa, 4-to-1 is likelihood of the caregiver being a woman versus a man.
Yeah.
It's a daughter, it's a granddaughter, it's a niece, it's a daughter-in-law. And then paid caregivers are more likely to be women. Our Brain
Mhm.
Health Navigator program that Norton participates in, all of our Brain Health Navigators are women.
Mhm.
And, if you think about like CNAs, who I think are angels on earth, large proportion of CNAs are also female. So this disease comes after women in a lot of different ways. And I think that's powerful. And I think that's powerful because I think women are powerful. Um, we don't take no for an answer, right? Whether that is someone in our community, in our neighborhood who needs help, we're there to help. Whether it's taking care of I always say they're the chief medical officers of their families, they're
Yeah.
doing all the appointments. But also we're the ones that said, for example, with mammograms and breast cancer, look what women did. We have power if we unite our voices and say, no, we're going to take care of our brains because our brains are important and we've worked too hard to get where we are to not pay attention to their health as we get older.
And, isn't there an increased risk of developing some mild cognitive dementias, or mild cognitive impairment or other dementias when you are a caregiver from that burden and that stress?
So it's really actually very, very recent that, in fact, it was just in September of last year that the Lancet published their meta analysis. Um, we've had the finger study and the Karolinska, and just this July, the US Pointer study, which is another lifestyle study, released. And they all say the same thing. So the Lancet study says you can actually prevent over 40% of dementia cases. Now, notice I said dementia, not Alzheimer's, but 40% of dementia cases with lifestyle change. And a big part of that lifestyle is stress.
Mhm.
I mean, there are the other things that we know we need to do, right? What's good for your heart is good for your brain. Diet,
Mhm.
Mediterranean diet, regular exercise, quit smoking, alcohol in moderation or not at all, tightly manage your blood pressure. Social engagement is really, really important. Cognitive engagement is really important. Managing that stress. And then the big one, which always gets women, is sleep.
Mhm.
Gotta have 7 to 8 hours of sleep every night. And, you say that to a 45-year-old woman who's taking care of her kids, working full time, taking care of her husband, taking care of her parents, and you say you need to sleep 7 to 8 hours, she laughs at you. And I'm here to say, no, no, no. Leave the dirty dishes in the sink and go to bed. Because that is the important time. That's kind of when the janitor comes in and cleans up the garbage that has been, you know, attacking your brain all day. And
Is
so
that what the G in glymphatic stands for?
yeah,
The
well, it's
garbage lymphatic drainage?
microglia, but it is a glymphatic system. But, it is really important, and you think about the things that disrupt our sleep, right? Alcohol. We don't sleep as well when we drink. Um, Lack of exercise. We always sleep better when we're regularly exercising. Stress. So you can see all these things coming together, and, it's one of the things that's really exciting because I think there's a lot of people that think, "Oh, it's just normal aging. If it comes for me, it's gonna come for me. I can't do anything about it. I don't have any control over it." And I'm here to tell you, yeah, you do. You have control over it. And the good news is if you go do these things, you're likely to have a beneficial impact on your cardiometabolic system as well.
Mhm. That's right, same things that prevent stroke, prevent
Abs
dementia, and
Absolutely.
And another element of like that layer of stress is, caregivers can get to feeling really isolated. And if everyone in the family is depending on one caregiver, that's like a really cumulative stress. And then they feel really isolated while surrounded by people. And so I'm really thankful that there's a lot more awareness coming to this and a lot more attention being brought to how can we provide emotional support and the value to that and not just think, oh, that's a girly thing that you need to talk to people or whatever. I mean, there are obviously male caregivers too, and they all need that psychosocial support from human connection and feeling seen and validated in the way that the people they are caring for probably can't do that for them.
Well, and it's even more important when you deal with someone that's living with cognitive impairment or dementia, because typically when that happens, your world gets very small, right? You stay at home more. You're not going out as much. You're nervous about being social with friends. You might say something wrong or forget something. So caregivers become isolated because they become the security blanket for that individual.
Mm.
And, what this data is telling us is that's actually the opposite of what should happen. And we have these wonderful examples, albeit anecdotally, of people who have decided to tell their story. And they could become advocates for policy. They could be advocates for clinical trial enrollment. They could be advocates for a lot of different things. But what they do is they go out and they tell their story and they meet new people and they're firing new synapses, right? Because they're
Mhm.
public speaking and they're traveling new places. They're getting rewarded with a purpose and a passion and, people telling them that what they're doing is good. And I'll tell you, anecdotally, the people who I know who've done that, they've actually decreased what I would have projected their decline to be. Does that make sense? They've slowed
Yeah.
their progression. I can't say that
Mhm.
scientifically because I can't tell you what it would have been, but I can tell you that they had a longer time doing that than you would have expected based on when their diagnosis was. And
And it improves their quality of life.
absolutely. And
Yeah.
we have spouses that have done it together, right? A
Mhm.
caregiver and a patient, and their relationship got stronger
Yeah.
because they were doing something like that together. And so I always tell people, I know this is a hard thing to talk about, but I'm here to tell you that if you want to tell your story, you're going to get positive feedback and probably do some good for your brain. And so to consider it. And of course, every time someone does that, it decreases stigma for everybody else, which is wonderful.
Exactly. And that's huge. Well, this brings me to the $1 billion question, Phyllis. Now, I know you're used to looking at big numbers, and sometimes big numbers are required, but the purpose of this is constraint, actually, and focus. Because as we're looking at these really widespread issues, um, we need to pinpoint and be strategic in our interventions. So, if you, Phyllis, were given a grant for $1 billion to meet the needs that you see in healthcare, how would you like to see it used strategically to have the most sustainable impact?
Oh gosh. I always ask this question of if you could wave a magic wand.
Hmm.
Um, $1 billion is a lot of money. If I could change one thing, just one thing, and I'm not sure if you actually need $1 billion to do it, although it would probably help because incentives matter in our health system. I would like everybody starting at the age 50 to get a cognitive assessment and then get it every year after that. Um, I think there'd be so much good that comes of that. If you think about it, we go to the doctor, we get our blood pressure taken. Nobody thinks twice about it. You just do it, right?
Hmm.
And what we know in cognitive assessments, we know that the best comparator is yourself.
Yeah.
I mean, there are these wonderful normative standardized databases and you can obviously compare yourself to your matched cohort, but really knowing your own situation. And so I think if we did that, a lot of things would happen. I think, first of all, we'd identify when this happens earlier. And whenever you identify something earlier, you give people more choices, more options. The drugs work better. You can enroll in a clinical trial. We are able to do more research. Like, I think there's this knock on effect there. But also, I think it would reduce stigma
Yeah.
because right now, the people who go get a cognitive assessment, it means your doctor's worried about you, or your
Hmm.
daughter's worried about you, or your husband's worried about you. And if everyone just did it, we would all just do it. And I think also if we were taking those tests, we'd be having conversations about our brain health. And I think it would have this great spillover benefit, not just in Alzheimer's disease, but think about it, stroke or um, mental health. You think about the stigma around mental health. I think if we started doing this and just said, we're going to take care of our brains just like we take care of every other organ in our body, if I could wave a magic wand, that's what I would have happen. And sadly, we could do it today. There's nothing technologically that's preventing us from doing this. So I guess if I were to use the $1 billion, it would be to get some more money to primary care physicians so that this just became something they did. Because obviously primary care physicians have a lot of stuff they're trying to jam into a very short appointment. And so if we could get them a little more space and a little more incentive, I'd love to see that be the big change for us.
So, as far as access goes, is there a way people could access this and take it without going to their doctor? Does it have to be administered by a healthcare provider, or is there a way they could access it online and do it?
Yeah, it's a great question. So there's lots of different types of tests. There's pencil and paper tests. There's now digital tests, which is amazing because the technology makes the tests better, right? And it takes out the human variability. And you can use AI and big data to, make the tests better. You can also task shift, right? So then it can be done by a less expensive resource in the health system, which of course is great.
Mhm.
So there's really two types of tests. So the ones that are done that are truly kind of a diagnostic tool or a diagnostic support tool is what they're called. They really have to be done under the guidance of a physician because they're just one part of a clinical workup, right? They'll also take
Mhm.
family history and medical history. They'll look at other things, your labs, blood tests, et cetera. So the ones that are truly if you will, a diagnostic or a diagnostic support tool, they need to be done with your doctor. Now, interestingly, they're required as part of the annual wellness visit. So every single person in this country over the age of 65 has a legislative right to one of these tests. They're required, but one thing that's okay is the doctor can just do their own assessment, which we know isn't good enough. There's so much data. So anyone who's over 65 can go to their doctor and say, I want this test. They just have to ask for it. It's their
Mhm.
legislative right. Unfortunately, it's not done in a standardized, validated test way.
It's not
Very-
uniform. It can be really subjective according to whoever is
Yeah,
saying, "This is how I'm assessing it."
it's not only it's not uniform, they may not do a test at all. They may just say, they said, how's your memory? Or they might just say, I assess the patient through our dialogue, which we know isn't good enough to catch these earliest signs and symptoms.
Yeah.
So that you do need to ask your doctor. And I think if more people were asking their doctor, I think it would happen more often too, right?
Because then they would feel the demand and, "Well, my patients want this."
Yeah, and I better go figure this out, right?
Mhm.
Now, there are ways you can buy a consumer grade test, or there are some freebies online. So, Us Against Alzheimer's has a free open access test on their website, which is called mybrainguide.org.
Mhm.
Mybrainguide, one word.org. You can go out there, you can take that test. It has resources if you want to go talk to your doctor.
Mhm.
It allows you to print things out so you can go talk to your doctor. It's a very nice resource. It is not a diagnostic. It is consumer grade. It is not a class 2 medical device. There are also some new companies that are coming online. Better Brain is one that I'm aware of, where you can actually pay out of pocket and you have kind of an app that you can take cognitive assessments. You can go get blood tests. It gives you things around supplements. If you wanted to really think about how is my diet, or how is the rest of my health because of this overlap with cardiovascular health. So for people who want to pay out of pocket, it's not extremely expensive. But but once again, those are consumer grade. They're not class 2
Mhm.
medical devices. At the end of the day, if you want to get a diagnosis, you really need to talk to your doctor.
Right. Do you feel like those things could be helpful if someone is under the age of 65? Like you were saying, you wish everyone started doing this at the age of 50, and they're not entitled to it according to law until they're 65. So, would you say that you would hope people would at least start with the consumer grade while that's available?
Yeah,
And then if
I use
it
them.
picks up on some kind of indicator, follow up and say, hey, this picked up on this. Can we look into it further when
Yeah,
they're with their
I use
doctor?
them both.
Yeah.
I use both of those things that I just gave, both for myself, and the nice thing about the My Brain Guide one is you can do it for a loved one, because a lot of times
Mm.
you might be concerned about somebody else. So,
Mhm.
yeah, I absolutely do. I mean, think about it. We pay for Noom for weight loss. Why wouldn't I pay for Better Brain to get a brain coach? By the way, they're not a client. They're not paying me to say this. I just
Right?
want more people talking about brain health. Oh, I
Yeah.
make my friends and family crazy, because I'm constantly wanting to talk about it, and they're like, "We don't wanna talk about this," and then the next thing I know, they start to ask some questions, and it's really amazing, actually, when you make some of these changes, how much better you feel. You think about menopause, brain fog that comes with menopause. There's a lot of things that we can and should be doing, as women that are coming into that part of our lives too. And so yeah, I'm a full fan of anything that helps us understand and learn more about our brain health.
Well, I love that because this is doable, Phyllis, and we
Oh,
can
yeah.
just be the squeaky wheels to make it happen. Or maybe someone will listen to this and become a squeaky wheel themselves. I like to say, you can squeak nicely.
You can My husband always says, "Just say yes, because 'cause you're going to anyway. She's not gonna give up." And
Right.
once again, that change agent, that tenacious person, and I think the more of us that are talking about brain health, you think about baby boomers, right?
Mhm.
10,000 of them turning 65, I think now 70 every day. They're
Wow.
not gonna sit back and give up that hard-fought 3rd chapter of their lives,
Mhm.
and I'm not going to either. That's the other thing, Rosa. All of these changes we should be doing in our 30s and 40s. We shouldn't be
Right?
waiting until our 60s to make the change. So I'm very, very hopeful. Now, none of these things, you're not gonna blueberry your way out of Alzheimer's disease, right? I think we have to be really careful that we don't, set false expectations. But I can tell you that you can make your brain and your body more resilient, and you can fight the disease better, just like you can fight cancer better or heart disease better if you do these things. The big difference with Alzheimer's disease is we're talking cognitive engagement, social
Mhm.
engagement, purpose, and sleep, which are a little bit different than some of the other diseases.
Yeah. But I love how you've tied it all together because it really is all connected. And so, thank you so much for making time to talk to me about this today, Phyllis. And I hope that this was enlightening for our listeners. So, if they want to reach out to you, maybe to have you speak somewhere or to learn more about the work you're doing, is LinkedIn the best place to do that?
Yeah, you can find me at Phil Farrell on LinkedIn, and that's the best place to find me. I'm on it a lot, and when I travel and go to events, I like to talk about what I'm seeing too. So if you want to follow along, that's probably the best place. And Rosa, I can't thank you enough to have another squeaky wheel
Yeah.
give me a little bit of space to just encourage people to let's take care of our brains. We've worked really hard to get where we are, and let's not let go of that without a little fight.
It's true. I mean, we have the privilege of all of these people behind us who have done all this research. So let's translate it into the real world and put it into practice. So, if you've enjoyed listening to this episode of the Nurse Rose's Insights podcast, make sure that you like and subscribe wherever you're listening, or if you're watching on YouTube, leave me a comment if you've learned something, or if you know another change agent that needs to have their ideas broadcasted and amplified. I would love to meet them. And you can follow me on social media at Nurse Rosa Speaks on all the different platforms. and I'll see you in the next episode.